Hello, my name is Bianca De La Rosa, and I am a student from Resurrection University's Health Informatics and Information Management program. Since joining the program in 2015, I've been learning about the HIIM domains, which describe the goals of HIIM professionals. We aim to improve the quality of healthcare by ensuring the most timely and accurate information is available for providers at any time to aid them in their healthcare decisions. We manage healthcare data and information resources. The domain I am focusing on in this video is about the data that is being created and circulated by healthcare professionals. The subdomains of interest are titled Classification Systems and Health Record Content and Documentation. I will be discussing the applications and analysis of quality and clinical resources appropriate to the clinical setting, including database management and coding compliance within the payment systems to ensure quality and cost effectiveness for rendered services. I will also address the application of existing and emerging technologies for the collection of clinical data, the transformation of clinical data to useful health information, and the communication and protection of data. To begin, I think it's best if I provide some definitions for you, since I will be using certain terms which are not commonly used from the dictionary. The first of which is what is a classification system? Now, according to the American Health Information Management Association, also known as AHIMA, a classification is a clinical vocabulary, terminology, or nomenclature that lists words or phrases with their meanings. It provides for the proper use of clinical words as names or symbols and facilitates mapping of standardized terms to broader classifications for administrative, regulatory, oversight, and fiscal requirements. Now, nomenclature is most simply called a system of naming things. Some examples of which are Healthcare Common Procedure Coding System, or HCPCS, and Current Procedural Terminology, or CPT codes. Nomenclatures are useful because they facilitate communication between providers, and the users have available the specific definition of the codes. Now, they are often confused for one another, nomenclatures and classifications, but they are not the same. An example of a classification system would be the International Classification of Diseases, or ICD. It groups diagnoses by body system and sequences related conditions together. The word terminology can be defined as a set of terms representing the system of concepts of a particular subject or field, also according to AHIMA. So when working in healthcare, medical or clinical terminologies are important. So another term used will also be lexicon, which refers to the listings of words or expressions in a language or terminology, and information about the language such as definitions, related principles, and description of structure. Everything is related that I have mentioned, and nomenclature or classification is related to terminology, which is going to be also called maybe the vocabulary that is being used by medical professionals, and what they're using is language, which consists of lexicon units. The reason we are discussing all of this is that one who is using all of these terms or using parts of this system must understand that it has to be communicated effectively. And the key to an effective communication is if both parties who are communicating have the same language, the same terminologies that they are using when they are speaking. This is where the term classification systems comes into play and why it is so important for HIEM professionals to understand them and use them. So now that we have discussed why it's important to understand classification systems, let's get down to talking about specific systems. The first of which, International Classification of Diseases, as I mentioned earlier. It is a classification system, also called ICD. It was first published by the World Health Organization many years ago, and it was adopted by the US, and it's up to its 10th revision, which was recently adopted by the US, and we were far behind the other countries, but we took it under our name finally and replaced ICD-9 with ICD-10. Another specific system is Healthcare Common Procedure Coding System, or HCPCS, also called CPT. It was developed as a standard coding system for claims processing and used mostly by physicians for billing purposes. The next system is Systemized Nomenclature of Medicine Clinical Terms, also called SNOMED CT. It was a standardized core general terminology used for an electronic health record, or EHR, which we'll be discussing more later. The next system is the Diagnostic and Statistical Manual of Mental Disorders. There are several versions of which I will be mentioning, the DSM-4, DSM-4-TR, and the newest is DSM-5. They are used to classify mental disorders and were sponsored by the American Psychiatric Association, or APA. The purpose of classifications, I already alluded to this, but I wanted to go more in depth with this. Clinical classifications, such as ICD-10, CMPCS, and CPT, represent similar procedures and diagnoses with single codes. This broad categorization of information is useful for functions such as billing and monitoring resource utilization. The classification system facilitates the storage and retrieval of diagnostic information and serves as the basis for compiling mortality and morbidity statistics reported by World Health Organization members. The main purpose for creating these in the first place was to keep track of how many illnesses and deaths were occurring in each nation at each time. I'm going to now focus on discussing each of the classification systems and nomenclatures that I've mentioned. First, starting with ICD-10-CM. As I mentioned before, ICD-10 was adopted worldwide quite a time ago, and it only took the US until recently for them to adopt the new version. It consists of more than 86,000 diagnosis codes compared to approximately 13,000 ICD-9-CM diagnosis codes. So this was clearly took a lot of effort and time, and they had originally planned to reveal it on a certain date, and then they had to push back the date because they needed to continue working on it. What's good about the ICD-10-CM is that it has more details, more codes, and it encompasses much larger of a list of diagnoses and incidents and anything that could possibly happen that physicians and providers are encountering in the real world today. And it's adaptable, which is great because things keep changing, and as healthcare and as the world changes, so must our terminology and so must our classification systems. It is maintained by the National Center for Health Statistics, or NCHS. It classifies diagnoses and other reasons for healthcare encounters. The code structure is alphanumeric, with codes comprised of 3 to 7 characters. ICD-10 codes have the potential to reveal more about quality of care, which is so important nowadays, so that data can be used in a more meaningful way to better understand complications. better design clinically robust algorithms, and better track the outcomes of cares because in the end, patient care should always be the number one priority for all healthcare providers. ICD-10 PCS is an adjunct. It is connected to CM. So whereas CM focuses on diagnoses, PCS was created to focus on procedural codes. It has 87,000 procedure codes, and it is a procedure coding system developed under contract by the Centers for Medicare and Medicaid Services, or CMS, as a replacement for the ICD-9 CM procedure coding system for hospital reporting of inpatient procedures. It has a 7-character alphanumeric code sequence, and I have a picture there as an example. Each number, each placement has a specific meaning. The first place is for the section in the book where it can be found. The second is for the specific body system. The third is for the root operation. The fourth is for specific body part. The fifth is for the surgical approach taken by the physician. The sixth is if there is a device that is used. And the seventh is for a qualifier. The next system I will talk about is HICPICS in CPT. It consists of 2 levels. Level 1 is called CPT, and Level 2 is called HICPICS. CPT is copyrighted and developed and maintained by the American Medical Association. It was composed of 5 numerical characters, and it's updated and published yearly on the first of the year. HICPICS is used to report products, supplies, and services not included in CPT. It is maintained by CMS. Its codes are 5-character alphanumerical. And as I mentioned earlier, these are the codes that are being used by physicians when they are doing their billing and coding process. The next system I will discuss is SNOMED CT. It contains codes for diseases and procedures. It is maintained by the International Health Terminology Standard Development Organization, or the IHTSDO, which is based in Denmark. It is the most comprehensive multilingual clinical healthcare terminology in the world. In 2010, the release of SNOMED CT included more than 315,000 active concepts, 806,000 active descriptions, and 945,000 defining relationships. Those relationships are what makes SNOMED so unique and so important because it takes into consideration how things are connected to each other. And it's very useful when making clinical decisions. The next system is DSM. DSM-4 was published by the American Psychiatric Association, or the APA, in 1994. DSM-4-TR, or they call the TR is for text revision because it's the revised version of the 4th edition. It came out in 2000, and the latest DSM-5 was released in 2014. DSM-5 has transitioned from DSM-4's multi-axial, or 5 axes, coding system. It has psychosocial and environmental elements that are captured with ICD-10 CM's Z codes now. The APA updates the DSM information to correspond with ICD, so they are meant to work in tandem in the healthcare environment. Now I'd like to discuss interoperability. Interoperability is defined as the ability to exchange information between computer systems. It's necessary for full use of EHR systems and quality of patient continuum of care. There are 3 types: basic, functional, and semantic. Basic interoperability relates to the ability to successfully transmit and receive data from one computer to another. The ability to understand or interpret the information being transmitted is not essential to basic interoperability. The next one is functional interoperability, which refers to sending messages between computers with a shared understanding of the structure and format of the message. With functional interoperability, the receiving computer can store information in a similar data field because the nature of the data being sent is understood. The third interoperability is semantic, and it is similar to that of the Health Level 7 HL7 EHR interoperability workgroup, in which the information being transmitted is understood. The use of clinical terminologies in EHRs to provide standardized data is essential to achieving semantic interoperability. There are other systems I would like to discuss now, including the Logical Observation Identifiers Names and Codes, LOINC, which is the exchange standard for laboratory results. LOINC was started in February of 1994. It's an exchange standard now that is being used throughout the world. The goal for LOINC is not to replace laboratory fields and facility databases, but rather to provide a mapping mechanism. Each LOINC name identifies a distinct laboratory observation and is structured to contain up to 6 parts, including analyte component, for example, potassium, hemoglobin, kind of property measured or observed, for example, mass, mass concentration, enzyme concentration, time aspect of the measurement or observation, a point in time versus an observation integrated over time, system and sample type, like urine, blood, serum, type of measurement or observation scale, quantitative versus qualitative, type of measurement or observation method, such as a clean catch or catheter. The next system I'd like to discuss is Rx norm, a standardized nomenclature for clinical drugs that provides information on a drug's ingredients, strengths, and form in which to be administered or used. Rx norm was produced by the National Library of Medicine, or NLM, and allows various systems using different drug nomenclatures to share data efficiently at the appropriate level of details. Its standard names for clinical drugs are connected to the names of drugs present in many other controlled vocabularies, including those available in drug information sources today. These connections facilitate interoperability among the electronic health record systems that record or process data dealing with clinical drugs, such as pharmacies, of course. Pharmacies and hospitals need to be able to communicate efficiently, which is why it's so important to have the same vocabulary being used. The next system I'd like to discuss is Clinical Care Classification, or CCC. It is two interrelated taxonomies, the CCC of Nursing Diagnoses and Outcomes plus the CCC of Nursing Interventions and Actions. It is used for documenting in hospitals, home health agencies, ambulatory care clinics, and other healthcare systems. This system increases the opportunities for health information and interoperability in the important area of nursing. Now, a term I used earlier was mapping. Mapping is defined as a function that allows for the reuse of data captured for one purpose to be used for other purposes. It has several categories. One-to-one, an exact match is made between the systems. Narrow to broad, a more granular term in the starting system maps, to a more general term in the receiving system. Broad to narrow, a more general term in the starting system maps to a more granular term in the receiving system, and unmappable if there is no match in the receiving system. This is what we said about LOINC, is that it was important because it helped when it came to mapping and interoperability between systems. Of course, we don't want it to be unmappable. The goal is one-to-one, or at least narrow to broad or broad to narrow. An example is that a laboratory system would manage data using the LOINC terminology and can map the LOINC terms to CPT codes to be used for billing purposes. Now I would like to discuss subdomain B, which is health record content and documentation. Although traditional paper records still exist in some organizations, significant progress is being made toward transitioning to a completely electronic record. It takes time, it takes money and effort, which is why some facilities are slower in transitioning than others, especially if they are located in an area that is struggling financially, economically, and they can't afford it yet. But they know that the quality of care will rise once they're able to switch to an EHR. So an electronic health record, or EHR, is described as a secure, real-time point-of-care, patient-centric information resource for clinicians, allowing access to patient information when and where needed. In this day and age, when we are carrying around our cell phones with access to the internet and we're able to speak to people across the world whenever we want, and we can share our faces and use Skype and Discord and chat whenever and wherever we want, it's so important when it comes to healthcare to be able to do the same. However, there's some issues that come up with that as well, mostly security. But I won't be discussing that just yet. Right now, I'd like to discuss the content of EHRs and what factors into them. Factors include provider preference. Do they have the interest in EHRs? A lot of them were hesitant. A lot of them were not comfortable, especially if they have been a doctor for many years and they were accustomed to doing things by hand or in paper, and they didn't want to learn something new, and maybe they found it frightening or threatening to their position. So some of them were not as comfortable or as willing to accept change. Another factor would be the healthcare process. How does the workflow in their environment, in their facility, will it be a hindrance or a help? Of course, now I think honestly that it would be more of a help than a hindrance, but the time it takes to do the training and the setting up and getting adjusted and accustomed to the new system would be a little bit of a hindrance and a burden at first. Of course, the type of facility is a factor. Some facilities are less able to factor in an EHR, not only because of financial reasons, but because of the type of facility. If they are a small business and maybe a small clinic that just takes care of a specific type of clientele, then they might not see the need to be using an EHR. Another factor would be the accrediting and certifying body standards. Accrediting agencies such as the Joint Commission have standards that the facilities and the providers would have to meet in order to be able to use an EHR. State licensure standards are very important for them since they need a license from the state to be able to practice medicine at all. And meaningful use incentives are very important as well, especially if they want to become a part of Medicare and Medicaid and be able to be a part of their program. They need to meet certain standards and regulations, especially when using an EHR. let's discuss more some of the things I just mentioned about those standards. The American College of Surgeons, the ACS, had a minimum standards of 1917. They were the first to develop standards that they realized they had to have other healthcare facilities all on the same page when it came to providing care. And it wasn't until the Joint Commission came along in 1952 that some more standards were developed for accreditation purposes. And ever since then, the Joint Commission has become the leading accrediting agency in the U.S. Medicare conditions of participation are guidelines and regulations under which facilities are allowed to participate in Medicare and Medicaid programs, which is also connected to the meaningful use, which I mentioned. The state licensure, as I said, the healthcare facilities must meet them in order to be able to operate. Health records today. They consist of contributions from numerous providers, either your main primary care physician plus some specialists or consultants, or maybe you don't have a main and you just go to multiple locations or whoever will accept your insurance. But anyway, you're going to have numerous providers putting documents inside of your personal health record. Information provided by the patient to describe their reason for visiting is included. Pertinent background facts. It's, of course, patient-centered. Number one thing is that the health records are about the patient. They're not about the doctors or the facilities. They have the input of everyone else, but they're all about the patient. The health record must provide evidence of diagnosis and justify the treatments that were performed to treat those diagnoses. This is all for insurance and payment, reimbursement purposes, of course. The health records also describe the patient's progress and response to medication and services. The outcome of care is, of course, very important to include in the health records. Did the treatments work? The basis for medical decision making for the providers must be included, and it is an important communication tool between providers and the patient, especially now with the creation of patient portals, which allows patients to send messages to their providers, check on lab results, set up appointments, cancel appointments, anything that they need now does not even have to be in person or over the phone because of patient portal systems. Let's discuss more about the EHR content. It incorporates patients' history, their demographics, their problem lists, their list of current medications, their allergies. They must be accurate because if they are not, then something terrible could happen to that patient. If they are taken to the emergency room at a hospital where they are not being treated normally, and if they do not access an EHR of that patient with the correct information, that patient could die, especially if they have a deadly allergy. Physician clinical notes are also included, follow-up notes, prescriptions, and laboratory and test results, which again goes to LOINC, which is why all the classification systems I mentioned earlier must be able to interact with each other, and interoperability is so important because no matter what part of the Medicare system, medical system that you are in, you need to be able to share the data and gain information that's valuable in order to protect this patient and treat them at a high quality level. The hybrid record is what the term that they're using now because half of documentation is still paper in most places and the other half is now electronic. So they're calling it the hybrid record. It is computer information systems and paper documentation. It is point of care. It is still paper that must be reconciled, so they do it via scanning or other electronic storage. There's usually someone who has to take the paperwork, type it up, scan it, whatever they must do to put it into the actual electronic system. The interfacing is important because the computer configuration allows information to pass from one system to another. EHR data. Clinical data is described as transcribed reports, history and physical, discharge summary, operative reports, all of which have their own rules and regulations for when they must be done, how many days after discharge, and what format they must be in. It varies depending on the facility, most often. And there's different types of paperwork and forms depending on the facility. But for the most part, especially in hospitals, there is a standardization for how it should look like and what it should include, and that it must be included nowadays in the EHR. They are signed and stored electronically. The digital signature is electronic means to identify the authenticity and integrity of the user's identification. This is important for authorization purposes to make sure that the right person who is authorized to have input on a patient's record, or that they were the actual provider of care for that patient, it must be proven with a digital signature now. This includes the date and time that it was electronically signed. Ancillary departments, including laboratory, radiology, pharmacy, they have access to the AHR because they need to be able to upload the test results. And that way the physician and the patient will be able to access it and look at it whenever they want. So data may be held in separate databases, which can be interfaced with the HIIM and/or financial systems. Record completion. CMS, accrediting bodies, and state licensure standards require that the health record be completed in a timely manner. The completion time clock begins running when the patient is discharged, he or she expires, or his or her treatment is terminated. Records are considered deficient or incomplete immediately at discharge. This is like I mentioned earlier, that there's always a time limit for when paperwork and forms must be done. Delinquent health records are those records that are not completed within the specified time frame. For example, within 14 days of discharge. The definition of a delinquent chart varies according to the facility, but most facilities require that records be completed within 30 days of discharge as mandated by CMS regulations and Joint Commission standards. Record retention. Now, when it comes to records, there are different phases. There is the creation and identification of the record. So the health record is created when the patient is first admitted to or treated in a healthcare facility. The next phase would be the storage and retrieval. Storage is the application of efficient procedures for the use of filing equipment and storage media to keep records secure and available to those providers and other healthcare personnel authorized to access them. The only time the EHRs will, well, not EHR, but the actual physical record will be retrieved is when the patient is due for a visit. They will take the chart out and they will give it to the provider to look through during the appointment. Now, when it comes to EHR, they don't have to physically bring it out, but they do need to be able to retrieve it on their computer at whatever office setting or location that they are at the time. The last phase would be the retention and disposition. Retention involves determining the schedule to be followed to protect and preserve active and inactive records. Disposition involves the process of destroying the records once the end of the retention period has been reached. Now, the retention period varies, and it's actually something that's kind of complicated, but it depends on the age of the patient. And state and federal laws and regulations must be reviewed to ensure that records are maintained for the longest length of time required. Many states recommend that patient health records be retained for 10 years following patient discharge or death. And there's usually special requirements for minors. For example, the state of Minnesota requires that the records of minor patients be maintained for 7 years following the age of majority. Therefore, the record of a newborn in Minnesota would be maintained until the patient reaches the age of majority, which is 18 years plus the 7 years. So it will be a total of 25 years. This varies from state to state because not all states consider 18 years old to be the age of majority. The retention period should also reflect the scope and needs of the facility, along with the preliminary costs associated with imaging, microfilming, and other methods of maintaining and storing records. So storage mechanisms should be selected that protect records and provide ease of access and employee safety. That's why now, more than ever, electronic records are so useful and important because it doesn't take up as much physical space in the facility as paper records do. They also have the possibility of renting a storage locker, like a storage vendor could be selected to ensure that the records are protected. When it comes to destroying records, after time limits for retention have been reached, the HIIM professional must decide on the destruction process for health records. It can be burned, it can be shredded, or destroyed in such a way that protected health information is not revealed. We must document the method of destruction, the date it was destroyed, and that record destruction is part of the normal course of business with no one particular health record or group of health records singled out for destruction. We should also include the description of the disposed record series of numbers or items, inclusive dates covered, the signatures of the individuals that were supervising and witnessing the destruction. We also have to be careful when outsourcing the destruction to shredding companies. Have to be carefully monitored to protect patient confidentiality above all.
I would also like to talk about the legal connections to EHRs. Now, the health record serves the legal interests of the patient, the provider, and the facility. It serves as evidence in legal cases addressing the treatment received by the patient or the extent of injuries. It serves to provide allegations for the patients in a malpractice case, and it's also used by the clinical provider and the facility to defend the care they provided to the patient. The record is admissible as evidence in court under the business records provision because the documentation occurs routinely as part of the healthcare facility's daily operation. The role of the HIIM professional when it comes to the legal aspects of EHRs is that they are the custodian of the health record. So most often, the HIIM professional will be the one called to testify when it comes to talking about the EHR on the stand. The longitudinal health record is a record compiled about an individual that contains encounter records from various encounters and from numerous healthcare delivery settings. It is valuable because all the information about a patient is maintained and accessible. It serves as a reference of past history and helps the provider avoid repetition of details and duplication of testing for the same conditions. Moreover, the longitudinal health record helps to prevent medical errors because information on allergies, drug interactions, surgeries, and past medical problems can be made available before treatment decisions are made. The physician can review the details of a patient's care and retrieve information needed at a later date. Longitudinal health record is difficult to achieve in a paper-based record system because the patient typically has records at a variety of provider locations, such as physician offices, clinics, and hospitals, each of which has a totally separate record system. This is why hybrid records are so difficult to deal with right now, and it's much better if they have everything electronic for interoperability and for the continuum of care for the patient to be as smooth as possible. Now, the provider of care is responsible for ensuring that entries made in the record are of high quality. This is where HIIM professionals also come in because they must work with providers, such as physicians and nurses, to be able to explain to them why the quality of documentation is so important, and that in order to properly document, they have to know laws, the states and federal laws and regulations for the documentation. Now, although the facility's medical staff bylaws establish the rules and regulations for record content, the individual care providers are ultimately responsible for the quality of entries they make and authenticate. This also includes legibility. If an entry cannot be read, it must be assumed that it cannot be or was not used in the patient care process. This is why nowadays providers should be grateful for EHRs, because if it's done through a computer system, you don't have to worry as much about your handwriting being legible, because that old saying about physicians' handwriting being awful is actually true. My mother, for example, was in the medical records at St. Elizabeth Hospital back in the day, and she said she used to have to suspend doctors because they were either delinquent in submitting their paperwork and the records and signing it, or their handwriting was barely legible to the point that they would get reprimanded for that. So that's why physicians should be glad that now things are electronic and they don't have to worry as much, but they still gotta work on their penmanship. Okay, at this point I would like to discuss about consent forms. Now, consent forms, I think I included earlier that they are included in the EHR. However, let's discuss a little bit more about them in detail. Now, consent forms are, of course, meant to protect not only the facility but also the patients, to ensure that they understand exactly what they are consenting to when it comes to their treatment and who can access their personal health information and who has the ability to use it or discuss it or anything. So, of course, under HIPAA, at the time of facility or prior to treatment by the provider, patients must be informed about the use of individually identifiable health information. This Notice of Privacy Practices, or the NPP, must explain and give examples of the uses of the patient's health information for treatment, payment, and healthcare operations, as well as other disclosures for purposes established in the regulations. So if a particular use of information is not covered in the NPP, the patient must sign an authorization form specific to the additional disclosure before his or her information can be released. In cases where the patient is coming to the facility for a specific procedure, an informed consent spelling out the exact details of the treatment must be signed by the patient or his or her legally authorized representative. This consent must show that the patient or the person authorized to act for the patient understands exactly what the procedure, test, or operation is going to be, including any possible risks, alternative methods, and outcomes. Another form that would be in an EHR would be an advance directive, which is a written document such as a living will that states the patient's preferences for care in the event that the patient's condition prevents him or her from making care decisions, such as being on their deathbed, or if they are in a coma, or if they have a case of dementia or Alzheimer's where they're mentally not able to make decisions for themselves anymore. It also can be in the form of a durable power of attorney for healthcare, in which the patient names another person to make medical decisions on their behalf if they're incapacitated. So when the patient has a written advance directive, its existence must be noted in the health record. Patients or family members may bring the document to the facility to show the patient's wishes in case of a terminal disease, injury, cardiac arrest. The advance directive can be included as a part of the health record, although its inclusion is not required. Rather than a formal written document, there may be documentation by the physician saying that they had a discussion with the patient or the family about the patient's wishes. A durable power of attorney, as I mentioned, for healthcare specifically, is a document that names someone to make decisions for the patient, and this person is often called a proxy or healthcare agent and can be a provider, a family member, or a friend. The advance directive goes into effect when the physician determines the patient is no longer able to communicate about healthcare decisions. CMS requires that Medicare patients be informed of their rights, including the right to know who is treating them, the right to confidentiality, the right to determine what visitors the patient wants to have, and the right to be informed about treatment. The patient's rights statement also must explain the patient's right to refuse treatment, to participate in care planning, and to be safe from abuse. The patient must sign a statement that these rights have been explained, and the signed statement must be made part of the health record. Some states often have laws and regulations about that, and they make it more important now than ever that patients know that they have rights. They also have rights to privacy in treatment, the rights to refuse treatment, and to refuse experimental treatments and drugs. So some other things that need to be included sometimes in a health record would be like a property and valuables list, especially if they are going for a specific treatment. Although most times the doctors and the facilities will tell the patients to leave their valuables at home, jewelry, watches, dentures, eyeglasses, anything, sometimes you have to bring them with you in order to be able to see, for example, or like a hearing aid. But they actually will include sometimes a list of those items, and then they have to sign a release of responsibility to absolve the facility of responsibility for loss or damage to their property. This form then gets added to the record. Other stuff would be, like I said earlier, the clinical data of the patient. Now I'd like to discuss more about clinical data, specifically about the history and all of the forms that the actual provider will be putting in. So the history is a summary of the patient's illness from his or her point of view. Its purpose is to allow the patient or his or her authorized representative to give the physician as much background information about the illness as possible. There are documentation guidelines for this, and they were published by CMS, and they affect physician reimbursement. Some components of medical history include the chief complaint, or the CC. The chief complaint is the principal reason the patient is seeking care. Present illness or history of present illness is the HPI. This component addresses what the patient feels the problem is and includes a brief description of the duration, location, and circumstances of the complaint. past medical history, this section is very important because it consists of questions designed to gather information about past surgeries, other illnesses that might have an influence on the current condition of the patient. The physician asks about childhood, adult illnesses, operation injuries, drug sensitivities, allergies, other health problems. Then the next section would be the social and personal history, which some people might lie about, and that is a problem when it comes to healthcare. You have to be 100% honest with your doctors at all times, because you never know, that thing you might be hiding from them might actually be a factor in what's causing you to be ill. So the social history uncovers information about habits and living conditions that might have a bearing on the illness, such as marital status, occupation, environment. Have you been on a trip recently? Do you smoke? Do you drink? Those kind of things affect your health, and the doctor must know about it. The next section would be the family medical history. The questions in there would allow the physician to learn whether the patient's family members have conditions that might be genetic. Common questions include heart diseases, kidney, cancer, diabetes, allergies, mostly focusing on immediate relatives, but anyone who is related to you might somehow pass along a disease. And of course, the age of the relatives when they died is important, and their cause of death is important. The last section would be the review of systems. This component consists of questions designed to cue the patient to reveal symptoms he or she may have forgotten, did not think they were important, or neglected to mention when providing their medical history. So it goes by body parts. It says, and is anything going on in your stomach? Is your stomach doing okay? Are you having problems with your back, or your vision, or your hearing? They'll actually go by specific body systems in order to say, you sure that everything's okay there? And if not, we'll just go down the list and we'll check. So it's very important that the person recording the history document whether the information was given by the patient or by another person, in case the patient is unable to communicate, or maybe they're too forgetful and that might be a symptom of their illness. Another thing that would be included in a health record would be the actual physical examination portion of a doctor's visit, where they will have a comprehensive assessment of the patient's physical condition through examination and inspection of the body. The physician usually tailors the physical examination to symptoms described in the patient's history, and the end of the exam should include the impression that they were left with, which is a list of the patient's problems based on the information obtained. So that's why the H&P, the history and physical, is very important to include in an EHR. Another thing I would like to discuss would be compliance with standards and laws and regulations. HIIM professionals are responsible for ensuring that the most stringent time requirements are followed so that the facility is always in compliance with state and federal laws and regulations, including licensure, as I mentioned earlier, the CMS conditions of participation and accreditation requirements. If you're in compliance, then the facility should be safe legally. But if they are not in compliance, then they will be facing penalties such as fines. They might even lose their license. They won't be able to practice medicine anymore. It would hurt the reputation of the facility and all of its employees. So that's why it's very important for an HIIM professional to emphasize that compliance is key to success. Okay, the last thing I will be discussing before I go back to my PowerPoint will be orders. Orders are also included in EHR records because they are the ones that the physicians are creating in order to communicate with other medical staff. Generally, they must be dated and authenticated manually or electronically by the treating provider responsible for the patient care. In the case of verbal or telephone orders, the provider should sign them as soon as possible after giving them. Many facilities require the ordering provider to indicate that the telephone orders are accurate, complete, and final by authenticating them in writing or electronically within 24 hours. Timing requirements for signatures on orders are governed by state law, facility policy, accreditation standards, and government regulations, and may vary from facility to facility. There are different types of orders, special types of orders. So there is a stop order, which is a certain category where like narcotics or sedatives are ordered to stop. That you don't have to have a specific time limit, that you just say, okay, you don't need to give it to them anymore at this time. We want you to stop right now. Especially if they are noticing that maybe the drug is too strong or the patient's having a reaction to it. Then there are some other orders like a DNR, a do not resuscitate order, which is documentation that the decision to withhold cardiopulmonary resuscitation or CPR was discussed with the patient and or the family, and the decision was made, and they have to have the actual time when the decision was made and who participated in the discussion and the decision, and it's often documented in the progress notes by the physician. Generally, patients are presumed to have consented to CPR unless a DNR order was already present in the record. They might also be part of the advance directives. There's also orders for seclusion and restraint, including drugs used for restraint, and they must comply with facility policies and CMS regulations, state laws, Joint Commission requirements. You should never be standing or as needed. Instead, such drugs must be ordered only when necessary to protect the patient and others from injury or harm. They have specific time limits as well. The most important order would be the discharge order. Now, discharge orders for hospital inpatients must be in writing and can only be issued by a physician. When a patient leaves against medical advice, or AMA as they call it, this fact should be noted in lieu of a discharge order because the patient was not actually discharged. In the case of death, some facilities require that a discharge to the morgue order be written. So that will be it for this portion of my presentation. My name is Bianca De La Rosa. Thank you very much for watching. And if you have any questions or comments, please feel free to leave it in the comments section. Thank you. Bye-bye.